Karina Town. Thank you for coming today on this beautiful day. I'm an account manager for RVNAhealth, which primarily means I'm in the business development department, but I do work really closely with the clinicians, our rehab area downstairs, and different offices like Ortho Connecticut. So RVNAhealth, we have many services, many departments, community health and wellness, individual health and wellness, chronic care and management, public health and safety. We have in-the-home nursing, in-the-home and outpatient rehab therapy services. We have our Parkin Center here in Ridgefield. We have our private duty services, Staying Well. So if you need a private nurse, private caregiver, or geriatric care manager, you can pay for those services. And then we also have our palliative care and hospice team. And today we have from RVNAhealth, we have Kate Campbell. She has, as you can see, many credentials, PT, CPT, SCS, certified MPT, CSCS, she's our director of outpatient rehab services right here in Ridgefield. She oversees outpatient therapy at RVNAhealth in our rehab and wellness center. She's a doctor of physical therapy, has her BS in health and exercise science from the University of Delaware. Pictures of your daughters, sorry.
Oh, no.
Oh, yeah, all right.
Yeah, I know. I'm not going to say.
Sorry.
All right, so I'm Danielle, I'm from Orthopaedic Specialists of Connecticut. We're located in Brookfield, and today we brought along Alison, who is our APRN, and she heads up our osteoporosis management and treatment. So she's going to discuss all of that good stuff with you all. But again, we're located in Brookfield, so we have other physicians that are with us, Dr. Sanjay Gupta, Dr. Daniel Fish, Dr. Benjamin Clippinger, who's in the back, Dr. Robert Dayer, and Dr. Antonio Paz. So they do interventional pain management and hand and upper extremity treatment and sports medicine and general orthopedics. So I want to thank Karina for allowing us to join with her today, and I guess take you next.
Yeah, there you go. Good morning, good afternoon, everybody. Thank you so much for having us. I just wanted to open up our talk, and here we are talking about osteoporosis, osteopenia. We want to give you resources and information to manage what you have via talking to your doctor, nutrition, and exercise. So osteoporosis, if you don't know, it's the bone thinning, weakening, and it can be diagnosed by a DEXA scan with certain scores, which we'll talk to. But I want to know who's here so we can tailor our talk. So who here has osteoporosis? Okay. Who has osteopenia? Okay, who has nothing and they just want to prevent it? Yay, thank you. All of you that have it, you've got to start telling your daughters, your granddaughters, because we can do the best we can once it's there, but it's way easier to prevent it. And we'll learn about when in the age and the life cycle are bone densities at their peak. If we can make the peaks higher, they don't go down as low later, okay? So I'm glad you are all here, and I want to get one misconception out of the way. You have osteoporosis, you have osteopenia, and you're stuck with it. It's only going to get worse. My osteopenia is only going to change to osteoporosis. True or false? False. I'm off, thank you. That was awesome. We already got that misconception out of the way. Yes, it can be managed. Yes, it can change. In fact, because I know John's not going to be here too long, this is John. He's not shy, wave. John came to this talk about 2 years ago after getting a DEXA scan that showed that he had osteoporosis. And he said, Kate, let's work together. I really don't want to do the drugs. The drugs are probably what got me in this place in the first place. What can we do? He met with the nutritionist, he met with me, we did one-on-one exercise, got him back to the gym, and today, isn't this so funny how the universe works? Today I got a text from John, and he said,
It's worked. It's a Facebook for 2 years. I followed the program that Kate asked me to, and I worked with her for about the first year, the physical therapy. And I enjoyed getting into the gym. You have to set yourself up for a daily routine of what you do. And when you go to the gym, it's just not working out, but you socialize there too with people. That kind of helps you go there all the time. So I was working out 5 days a week. And when I had the test and got the results today, I'm proving that Kate's program does work.
Right. Yeah. I would love to take the credit, but it's research. The research has proven that we can make a difference with the right prescription from a physician, the right nutrition prescription, and the right exercise prescription. That's why now we are doctors of physical therapy, because we do prescribe exercise. And so specifically, John's T-score stabilized at the hip. We'll learn that's a big win. And his spine T-scores improved. It can be done, and here is proof. I'm not just saying it. So I'm glad you're all here. We want to reverse it. We can make a change. Just wanted to give a visual of like what's happening deep down in the bone. You see how thick that normal bone is? There's not a lot of airspace, and osteoporosis looks a lot thinner. So of course, with the right force, a fall and your hand is out. A fall down anywhere in the spine, in the hip. The hip is actually very vulnerable, can cause a fracture more easily than if I fell down, let's say. And later in life, we hear compression fractures happening from just sitting because we're sitting and flex and that's too much pressure on the vertebrae, on the spine bones. So why is this a big deal? Medicare cares because it costs them money. 10 million have osteoporosis. 50% of women with osteoporosis, 25, will actually fracture from osteoporosis. And this is really scary. When you fracture a hip, not everybody makes it because of what happens after. I mean, very rarely will the hip actually cause an issue and a bleed, or very rarely will you have something go wrong with surgery, but it's the fact that you don't get back to doing what you were doing, and then you have heart issues and lung issues, and that's scary. We really got to protect that. It costs Medicare money. They don't like spending money, so this is why it's super important. Where do the fractures happen? A lot in the forearm and the wrist, a shoulder, hip. If you, when we think hips, it's not really this. It's right here at the neck of it. So if you do like the sassy teenager thing and you stick your hip out, it's right in there. And then also in the spine. It happens way more in women, and we will learn it's related to hormones and menopause. If you have a fracture, you are 86% more likely to get another one. So let's learn about what's actually happening to the bone, how the environment sets up the bone healing, and what happens so that you can take all that nutrition and exercise talk and apply it. So I'd like to introduce Alison. Thank you.
Thank you, everyone. I appreciate you coming today to talk a little bit more about this very important topic. So we'll start with the normal bone cycle. So our bone is a living tissue. It's always regenerating. It will look for tiny little trauma to the bone. Then the osteoclast will come to that area, start to break down the bone. The osteoblast will then come, rebuild that bone, and this cycle just continues throughout our entire life. Every 7 to 10 years, we can have a whole new skeleton because this is constantly regenerating. So as our bone is breaking down, we need to make sure that we have all of the right things to help rebuild it as well. So sometimes there's some things that are off in the balance of our calcium, which is a huge piece of our bones. So in our normal bone cycle, we would have this perfect normal calcium level in our blood. It would maintain in our bones. Everything would be great. If we have a decrease in our calcium level, our thyroid's going to kick in to increase that absorption in our bones, increase the uptake in our intestines, and also from our urine. If we have a low calcium level, our parathyroid is going to kick in.
and do the same thing. It's going to start to pull that calcium from the bones because our body wants to maintain this homeostasis all the time. So if we're not getting enough calcium in our diet, our body's going to look for it other places. And the first place it looks for it is in our bones. So it will start to pull it from there. That's not what we want it to do. We want our body to store the calcium in our bones to keep them strong. Again, the intestines are involved, the kidneys are involved, so this cycle is going to constantly be trying to maintain itself. So this is a very important piece of part of the talk that we'll go into a little further. So what makes perfect environment for bones? So your calcium is the building blocks for your bone. So we get that in our diet, hopefully. But the calcium really isn't super effective unless we have vitamin D there to help your body to absorb it. Estrogen is another piece, especially for women, that helps to keep our bones strong. But after menopause, our estrogen levels drop, so that helps, or does not help the bone, and increases our, or lowers our bone density. Stress, although it sounds like a bad thing, is an important thing for our bones. We have to constantly be stressing our bones so that they're working harder to rebuild their strength. And Kate will talk a little bit more about how we're going to do that. But our bones need weight-bearing exercise in order to keep them strong. If you're sitting around, not really moving around, your muscles get soft, your bones get soft, everything just gets soft. So we really want to challenge our bones and continue to work them hard so that they will stay strong. So in the normal bone cycle, when we're born, all the way up through puberty and our early 20s, we're really building our peak bone mass. That's the time where nutrition is very important, exercise is very important, because as you can see, the gray area there is more of the men, the blue area is the female. So men are going to have more bone density than women just because that's how we are designed. But building that bone density in those younger years can really help later on, because that's the time when we get to that peak bone mass at around age 30. Imagine that. That's where we're at our best for our bones, and then we start to go down from there. We do have a rapid decline right around that postmenopausal period, so really maintaining during that time is very important. So what can we do about this? So talking to someone who really looks at osteoporosis, whether it be your primary care doctor, someone like myself, endocrinologist, rheumatologist, all different doctors really focus in this area. There's different medications if we get to the point where your osteoporosis is very severe, but really we want to not have to get to that point. That's why we're here today, is talk about how we cannot get to that point. So targeted nutrition is very important. There's a lot of pieces in our normal diet that we may be missing that our bones really need to stay strong. And targeted exercise is also a very big piece of it. The data shows that weight-bearing exercise makes a very big impact on your bone density. So what can we do? There's multiple tests that you may have done when you go to your doctor to really determine where you are in this realm. When we talk about osteoporosis, osteopenia, and normal bone density, we want to go through the different tests, which I'll go into in just a minute. Really look at your risk factors, because that's another big piece of it. Yes, we can have this test that shows what your bone density is, but if you're at very high risk because of certain medical conditions, certain medications you may be taking, these can make us look at it a little bit differently. And most importantly, don't be scared. This is something that's very manageable. We all have a lot of control over how we can manage this disease. You just have to know the information and put it to work. So when we talk a little bit about different tests that might be done, certain blood tests to look at your CMP, which is going to look at a bunch of different blood levels, phosphorus. Your thyroid is a big piece, as we talked about earlier, which could cause you to have decreased bone density if it's not working properly. Your parathyroid. Your vitamin D level is very important, again, because that's what's going to help you absorb the calcium. So maintaining a good vitamin D level is important. And sometimes you may have a 24-hour urine collection done to see if you're excreting calcium in your urine, which would not be a good thing. Then we talk about the DEXA scan. Most everyone, I'm assuming here, has either had one, heard about someone having one. So this is a test, which I'll show you what it looks like here. We get a fancy report that shows the lumbar spine, which is the lower part of the back, and the hip. We'll look at the total hip and the femoral neck, which is that kind of skinny part right in the middle there. which is a common place for people to have fractures. So we want to know all of these different areas of the body, which will determine what your bone density is. And then once we get all of these numbers, and you can see all of these little boxes there, we take those numbers and we come up with what's called the T-score. And when we look at your T-score, you'll either be categorized into normal bone density, osteopenia, or osteoporosis. So normal bone density, we're doing great. We want to stay there as long as we can. Osteopenia, that's when your T-score is somewhere between -1.0 and -2.5. And then when we get into osteoporosis, that T-score is less than -2.5. So that's really where that bone becomes very porous, like we saw in the slides earlier, and that's concerning because your risk of fracture is much higher when we get to that point. So there's different risk factors. There's modifiable risk factors and non-modifiable risk factors. Some of them you have the control to change, other ones you don't. When we talk about non-modifiable risk factors, age. As we age, our bone density is going to decrease. How quickly that happens, we'll talk about slowing it down. Family history, typically if your mom had osteoporosis, your dad had osteoporosis, you're likely that you may also have osteoporosis. Low body weight is another one that not often, that is a problem, but when it comes to your bones, having a very low body weight or a BMI under about 19 can be a risk factor as well. Poor diet as a young age, again, because when we're building that bone in those puberty years and up into our 20s, that's really when we want to be eating a very good diet. So as Kate said earlier, telling your children about this, your grandchildren about, really eating a good healthy diet to build those bones as strong as we can so you don't end up having weaker bones later on in life. Lack of loaded exercises, again, really challenging those bones during those prime bone building years is important. Certain endocrine disorders, rheumatologic disorders, gastrointestinal, those can all have an impact on your bones as well for a variety of different reasons. For men, testosterone deficiency can be an issue, and women, for estrogen deficiency, especially if you go into menopause before age 45, can be a risk factor. Again, things we can't really change very much, but are all part of the puzzle when we're talking about looking at osteoporosis in the big picture. Modifiable risk factors. So 3 of the 4 are very much modifiable. So sedentary lifestyle, we all have control over, what we do in our day. Obviously, there's limitations due to injuries, other types of medical condition, but we can all do something, and really trying to find what that perfect thing is that we can do is important. Current diet, making sure that you're getting the right nutrition to be able to support your bones is important. And then alcohol, tobacco use, those are also very important. Any moderate amount of alcohol is not good for the bones, and tobacco use of any amount is really not good for the bones either. When we talk about long-term use of medications, although it's a modifiable risk factor, these medications that are listed here are ones that really can do some harm to the bone, but sometimes we need these medications to treat other conditions. So in a sense, they are modifiable, but also not modifiable if we want to fully treat the other condition that we're using them for. So really having a good conversation with your doctor, why you're on those medications, are they necessary, are there other medications that are less harmful to the bone, is a good conversation to have. So again, don't be scared, we can do this. We can definitely treat osteoporosis in a variety of ways. When we're looking at, the risk of fracturing versus the risk of living your life. Things we can do on a normal daily basis. Fix your posture, keep a good strong back. That's really important for supporting the spine, for supporting your whole vertebral column to make sure that those bones are getting the support that they need. Avoid falling. That sounds much easier said than done sometimes, but there's lots of things that we can do to prevent that. Balance exercises are very important, really on a regular basis, maintaining those exercises. Learning how to fall. Kate does a class on falls and how to fall properly.
Tomorrow, Sherman Library, 11 a.m.
There's a little plug for that. And really don't stop moving. If you really stop moving, you're going to lose it. So we want to really keep our bodies active, keep them moving, keep challenging them. So what can we do here? Get tested. Have our DEXA scan done any laboratory test that your doctor may find is necessary to fully work up your osteoporosis to make sure there isn't a secondary cause of osteoporosis and what's going on there. Really looking at your risk factors, which ones can you control, which ones can you not control, and are there some that we can modify? And really just, taking hold of this and doing all that you can to improve your bone density. So when we talk about nutrition, this is a very important piece of this whole process. So osteoporosis, if we're going to look at the nutrition hierarchy, starting at the bottom, really focusing on an anti-inflammatory diet is very important for your bones. Mediterranean diet is really a good diet that is going to support the nutrition of your bones. Moderate protein. Protein is definitely important for maintaining your muscle as well as your bone. Calcium and vitamin D are really the building blocks for the bones. Vitamin K2 is something that's also important for the bone. Selenium. And right at the top is prunes, which is an interesting one. Prunes are really power-packed with all kinds of things that are good for the bones. They have phosphorus, they have magnesium, they have boron, they have vitamin K. So they're a wonderful addition to your diet if one you like prunes and don't have any issue with them. Anti-inflammatory diet. Really this includes unprocessed, plant-rich whole foods. Really focusing on fruits, vegetables, whole grains, looking at healthy fats versus the saturated fats, making sure you're getting enough protein every day, vitamins, minerals, and of course hydration. We need hydration for our bodies to work properly. So protein is definitely an important piece of building your bones. Here there's some very good examples of some high protein foods: tempeh, tofu, sardines, yogurt, salmon, milk, body with what it needs to stay strong. Calcium. This is one of my favorite things to talk about. Most abundant mineral in the body. So calcium is so important for not only our bone health, but our blood vessel contraction, dilation, muscle function, blood clotting, nerve transmission, hormonal secretion. So the calcium does a lot of jobs in our body. 98% of it is stored in our bone. But if you're not getting enough in your diet, your body's going to start pulling it from your bones. And when it starts pulling it from your bones, that's going to weaken them. We don't want that to happen. So maintaining a good amount of calcium in our diet is very important. One of the tricky parts is, though, when we're looking at all of these blood tests to determine, what's the right amount of calcium, what's the right amount of vitamin D, vitamin D is an easy one. It's pretty close to, we know if you're taking this much, your level is this much, we can adjust if it's too high or too low. Calcium doesn't give us exact science of how much you're taking in. So if you go to the doctor, your blood calcium level is normal, doesn't necessarily reflect what you're getting in your diet. It's going to be, again, going back to one of those first slides, if you don't have enough calcium in your diet, the parathyroid is kicking in and it's going to start pulling it from your bones, and we don't want that to happen. So, I was talking about the DEXA scan here. That's going to really give us an idea of the strength of your bones, not necessarily the exact calcium, but knowing if you're getting enough to be able to support that. And the recommended amount for people over age 50 is 1,200 milligrams a day. That's between diet and supplement combined. So really getting it from your diet, your body's going to absorb it much better than any supplement you're going to take. It also gives it the opportunity to break it up throughout the day, because if you take a whole bunch of calcium in the morning, your body can only absorb so much in one sitting, so you're not going to get that full effect. Even though you say, well, I took 1,000 milligrams in the morning, your body's going to get maybe 500 from that, maybe. That's, a rough estimate. So dividing it up throughout the day is much better. So again, low calcium is bad. More calcium isn't better. Bigger is definitely not better with calcium. If you're prone to kidney stones, too much calcium can exacerbate kidney stones. There's also some question whether excessive calcium can have an impact on your coronary arteries. So we don't want to go big with calcium. We really want to look for that happy medium, and the 1,200 is just right between your diet and your supplement. So again, calcium is definitely better in smaller doses. Diet is the way to go. Spread it out throughout the day. Multiple different sources are good for your diet: milk, cheese, cottage cheese. Some people will say to me, I just can't tolerate dairy, I just can't do it, it doesn't agree with me, but there's many other places we can get calcium. So collard greens, kale, the dark leafy greens, they're going to have a very good deal of calcium. Sesame seeds, things like hummus, because it's got both the chickpeas which have some calcium, as well as the sesame seed in it from the tahini. Fortified foods with calcium, white beans. So there's many different options. It's just finding what's right for you, what you tolerate, and trying to spread it out throughout the day. So here's a little example of how we can get enough calcium in a day. So working to say 300 milligrams is really our goal for each of our doses over 4 times per day. So for breakfast, if you have a bowl of oatmeal with a glass of milk either on the side, or prepare your oatmeal with the milk, you're going to get even more than 300 potentially in that right there. Lunch, you have a yogurt with some chia seeds in it. That's going to give you another approximately 300. Then, we all have to take a little break from some of those foods, so maybe adding 300 milligrams of supplement in the middle of the day if you're having a snack, a piece of fruit, taking your supplement at that time, and then with your dinner having an ounce of cheese. And there you go. There's your calcium for the day. Seems pretty doable to me, but it depends on everyone's diet. You have to modify, and sometimes working with a nutritionist is the best way to really find those pieces of how you can make that work. But it is definitely doable to get the calcium in your diet. Vitamin D is important for your body to absorb all of this calcium that we're trying to eat. So we want to have your levels checked if you haven't had it checked. Somewhere between 30 and 50 for anyone who has osteopenia, osteoporosis is really the goal to keep it at that. 400 to 600 IU a day of vitamin D is for the average person. Someone who does have osteoporosis or osteopenia, we're looking a little bit closer from 800 to 1,000 international units a day. And if you have deficiency, you definitely want to talk to your doctor or provider, because we want to make sure that we're getting enough vitamin D to support the calcium absorption and support our bones, as well as the rest of our body. Another thing I have questions often about, vitamin K2. So vitamin K2 is definitely an important piece of our bone health. This one is a little bit different as far as the recommendations, just because some people can't have extra vitamin K because of certain medications, certain medical conditions. So definitely something I would recommend talking to your doctor about before you start supplementing any K2 or adding any large amounts of it, because it can have an issue with certain medications that people are taking. Selenium is also another important piece for our bones. It's an antioxidant that is found in many foods, lots of meats. Depends on fruits and vegetables and the soil that it's grown in, but selenium is abundant in those type of things. Brazil nuts are one of the most power-packed selenium foods. One Brazil nut will give you your recommended daily allowance. So I think we can all probably tolerate one Brazil nut a day to get the selenium that we need and not have to worry about supplementing at that point. And back to the prunes. They're just a great food. They really have so many things to offer. Oftentimes, patients will tell me that they have constipation from their calcium supplement, that it really bothers their stomach. So the prunes help to balance that out, as well as giving the nutrition that we need for our bones. So here's kind of, from a nutritional standpoint, a very good recommendation for keeping your bones healthy. So the Mediterranean diet, really sticking with that, lots of healthy fruits and vegetables, making sure you're getting the whole grains, protein with every meal. We want to make sure that our bones and our muscles are getting enough protein to keep them strong. 1 300 milligram supplement during the day to increase our calcium intake, and then 300 milligram servings in our food. 1 Brazil nut, that magic Brazilian nut there, 5 to 6 prunes, and then the K2 there is the one, again, don't want to just blanketly put that across for everyone, but a tablespoon of natto, which is a fermented soybean product that people can use, or taking a K2 supplement is something that also could be considered. And then vitamin D supplementation if needed, if you're not getting that really in the diet. Some of of the anti-nutrients that some people will talk about as well, vitamin A in excessive amounts can definitely have a negative effect on your body. So sometimes when we're looking at a multivitamin or some other supplement that you're taking, looking at the recommended daily allowance and making sure that it doesn't have excessive amounts of vitamin A in it, because that can definitely be a negative effect on your bones. Sodium in excess is also another one that doesn't work well for your bones, so really having a good idea of how much sodium you're taking in a day is important. Caffeine in large amounts is not good also. Moderate caffeine intake, 1 to 2 cups a day is not going to have any major impact on your bones. But definitely if you're drinking 6 or 7 cups of coffee a day, you might want to cut back and really consider that it is having a negative impact on your bone. Phthalates and oxalates are something that it's in multiple different foods, like spinach, for example. Spinach is high in calcium, but it has the oxalates in it, which kind of blocks the absorption of the calcium just from that food. So even though it does have the calcium, you're not getting quite as much as some other foods. Not that I discourage you from eating it by any means, because it's very good for you, but when we're talking about looking at how much calcium we're getting, we have to take all of those things into consideration, and that's why working with a nutritionist is definitely a good thing to do to get that perfect balance of all of the different things that we need. And that finishes my portion. Kate will come up and talk a little bit more. Any questions up until this point? Sure.
If you cook the spinach, does that help versus just eating it raw?
No, it still has the oxalate in it, so it will still be there, but you're still getting some calcium. It's just blocking some of it. So it's not something that I would be tremendously concerned. And like I said, don't stop eating spinach. I definitely don't want that to be the point of the story here. So, yes.
I'm lactose intolerant, and I eat and drink a lot of non-dairy products. Do they have sufficient calcium in them? I have to read their labels, I guess.
Yes, you definitely have to look at the labels, because things like soy milk, almond milk, a lot of times will be fortified with calcium. But it depends, because if you look at, organic almond milk probably is not going to have a lot of calcium in it because they're not fortifying it. When it's organic, they're usually putting the least amount of things in it. But if you go to certain stores, Stu Leonard's, for example, bought almond milk from there, 450 milligrams of calcium per serving in one serving because it's fortified. So there's a very large difference between them, so it's really just looking at the labels there. But you're getting the calcium definitely. It doesn't have to come from dairy, that's just the natural source that it's most readily available. Yes?
Hi. I had read that it's better to take calcium like in the afternoon if you're doing a supplement, because the body can absorb it better. Is that true?
So when you're taking calcium, there's multiple different types of calcium that you can take. So there's calcium carbonate and calcium citrate. If you're taking calcium carbonate, you should be taking it with food because you need that to be absorbed as well. If you're taking calcium citrate, it doesn't necessarily need food to be absorbed, so it's probably related to which type you're taking. So, but it's definitely better, I think, in my opinion, during the day, because some people do have some irritation in their stomach from taking calcium. So if you're taking it early or on an empty stomach, it may bother you a little bit more. If you're taking it later in the day, you may have less likely, stomach upset from that. Any other questions?
I have a question. I'm so happy I can ask this. So I had heard, probably not from a reputable source, so happy to get it, that the DEXA scans, like the mobile DEXA scan, like come to the health fair and get your bone scans. Are they specific enough? Are they trustworthy enough?
It's more of a screening tool. It's not something that they're going to diagnose and treat you with that type of tool. So those will usually they'll use your heel or something like that. You put it in. If you have very, very low bone density, then they're going to say, okay, we need to look at this very carefully. Again, it's one very basic screening tool, so I wouldn't take it too much to heart, either way, but definitely a good thing to look at earlier than later.
And I also heard that the DEXA scan machines may be calibrated different, like practice to practice. So is it a good recommendation to always try to get the same machine?
That's correct. You can't really compare apples to apples if you go to different locations. So if you go to one location, let's say you went to whatever's here in Ridgefield Diagnostic Imaging, you would want to continue going to that same location because they'll be able to look at your old scores and compare them. If you go to different locations, the machines are a little bit different, so you're not going to get one that you can look side by side. So if I look at it and say, okay, this is what my numbers were 2 years ago at a new location, you're kind of starting from scratch. So sometimes we don't have the ability to go to the same place. I have many patients who have moved here from other states, so we start from scratch with the new one, but definitely best to follow in the same location.
And you have medical bone density testing like at a hospital, and do you also need to have the DEXA scan?
That's the same test. The DEXA and the bone mineral test is the same, yeah. So bone density and DEXA is really the same test.
Because a doctor recommended the DEXA scan to me yesterday, even though I had just had a recent bone density, so I didn't see why.
Okay. Yeah, maybe they didn't realize you had one done recent. Oh, okay, yeah, the DEXA is the bone density test, so. Did you have a question?
Along with the exercise program that I was on to improve my osteoporosis, I was on calcium that had a diet of, when I woke up in the morning, I had soy milk and I had some fruit, mandarin oranges and grapes. And about every 2 hours, I would have 8 ounces of milk. And that was because your body can't absorb more than, I guess, 300 milligrams. So that was the only part I was adding to my exercise program. Nutrition.
And that's the best way to do it, really dividing it up throughout the day. Your body's going to absorb it much better that way, so good work. Yes?
Vitamin D, that is fat soluble,
Yes.
right? So it should be taken with food, that's.
Correct, and you don't want to overdo it on the fat-soluble vitamins. That's why, again, bigger isn't better. Your body's going to store what you're not using. So if you're taking too much vitamin D, some people think, well, if I'm taking 1,000, well, 10,000 has to be way better.
Right.
Definitely not the case. Your body will start to store it in your fat, and after a while, it will become toxic, and we definitely don't want to get to toxic levels of any of our, vitamins or minerals. That's really defeating the purpose if we're overdoing it, so.
What's the distinction between carbonate and citrate with the calcium?
They're just different forms of calcium, so really the carbonate is the one that you want to have definitely with something. Yeah, carbonate is going to be with food. Calcium citrate is going to be, you don't have to take it with food and you'll still get the absorption. Did you have a question?
I always get a little confused between osteoporosis, the effect of osteoporosis, and like low thyroid. Is that actually like the level of the thyroid that affects the bones, or is it if you're taking Synthroid, does it affect your bones, or both?
It's more when the thyroid is not working properly. So if you're taking your medication, your levels have been maintained, then it's not as much of a concern. It's really untreated thyroid disease, or if you're not taking your medication properly, your levels are not really maintaining, that's when it's a little bit more of a problem. Well, thank you, everyone.
Awesome, thank you so much. All right, the last piece of the puzzle is getting moving. So how about we get moving just for a minute? Everybody stand up. Yes, give it a big stretch. Oh, that's so good. We're physical therapists, so we can't be sitting for too long. And sit back down. And get back up. And sit back down. That's one. Here we go. Sit. And stand 10 times. Down. And up. Hey, we're working. This is a weight-bearing exercise. How easy is this to just add when there's a commercial break or something, because we are loading our bones thanks to gravity. This probably would actually be way worse if we were on the moon. But thanks to gravity, but we got to use it, right? So there is this law called Wolff's Law, and it is tried and true. If you give bones stress, we talked about it's not like emotional stress, it's force, they must change. It must happen. So the prescription comes from how much do we give it to make it better, because I'm sure there is a magic threshold that's invisible, we don't know, where it's too much and causes a fracture. Right? So let's look at what exercises we can do to give the right stress to provoke Wolff's Law and make our bones stronger. When designing the right exercise prescription, we want it to be specific, we want it to be progressive, we can see reversibility in our T-scores. It depends on the initial T-scores, and of course, you know, the better you are, the less improvement you can get. It's almost like the lower you start, the more change you can get. So specificity. What I mean is when we do our exercises, let's make sure we mimic life. So here's a woman doing a deadlift. It looks a lot like lifting the groceries, right? And she's doing a farmer carry with a step up because she's got to put the groceries away and she's got to go put it overhead. And got to get on the floor to get that dog bone, right? So we're doing burpees. Yes, if we can design a program that's not just sitting here and lifting one weight at a time to work one muscle or one bone, we're going to get better results. And honestly, in the world of physical therapy, we look at when it's functional to you, and you go, I'm doing this so I can lift my grandchild. I'm doing this so I can keep up with my husband who's walking fast. You're actually more likely to do it and more likely to improve. So we want to make the exercises specific. We need them to be progressive. What's a wonderful part about the human body is we adapt. If you adapt to a certain weight, you know, 5 pounds was hard and now 5 pounds is easy, so I'm just gonna keep it at 5 pounds. You're not gonna get any better. You're only gonna keep being able to lift 5 pounds. So next time is 6, next time is 8. Oh, that was too much, back to 7, right? So we want to keep progressing in the weight the right way and safely. We have proven, John is proof, that with these exercises we can actually reverse our T-scores, but the lower you start, the bigger change you can get. And then when you get better, the progress is slower, but slow progress is still progress, right? And the later you go. So let's think about this exercise program. I need it to be adding weight, adding resistance, because the weight on our skeleton is what's changing the stress and making the bone change. So that's why this low body weight, everyone's like, I gotta be skinny, I gotta manage my weight. It's the only bad thing that comes with having really healthy weight, is that you on this earth and gravity for all those years haven't had to put a lot of force on your bones. So those who are heavier have been putting force on their bones for their entire life. So we need to add more force via exercise to keep stimulating the bone. We need to add speed and we need to be weight bearing. So when we talk about progressive resistance, we're increasing the weight like I talked about. When someone goes to the gym, they've done a study, and they say, go ahead, go lift weights. And then the researcher comes over and said, what weight did you do for the leg press? Oh, cool, what weight did you do for your arms? And then they say, I wonder how much you could actually do. We call that a 1 rep max. How much could you lift if you only got 1 try? When people go to the gym, they tend to choose 30% of their 1 rep max. It's better than 0, I guess. But it's been proven that you need 60 to 70% to actually make muscles stronger. Weightlifters and Olympic lifters, they're operating in the 90 percentile. So we'll talk about how much should you do and safely. This is an example of some resistance training. We're lifting weights. We're lifting weights overhead. There's our same woman who was doing burpees. Look at this clientele in the gym, right? It kind of looks like here, right? Maybe they're definitely much older. You guys are way younger. But they're lifting weights. It's effortful. It's fast. It's not too slow. There's something about the speed. So when we're trying to stress the bone, we need gravity plus weight. I mean, literally walking with a weighted vest even. But then it's the force on the bone, but it's also our muscles tugging on the bone. So I have my bicep here, it's so big, right? And it attaches from point A to point B. When I contract my muscle, it's tugging on point A and point B. And the tug on the bone is what signals to the bone, hey, I gotta get stronger. I have to be able to handle this force. So even though we're lifting weights to give our bodies almost more weight, like to be heavier. We're trying to work the muscle because of where it tugs on the bone to stimulate change. Does that make sense? So when we do some of these exercises, they need to be fast, explosive, like a snatch or a clean or jumping. So here's an example of some speed. Power up, slow down. Power it up, slow it down. Notice he's bending over and he's not breaking. I literally had a patient when I said, great, let's do an evaluation and see where you are, see your baseline. Let me see how your spine moves. Can you bend over, touch your toes? And she goes, I was told to never bend over. I was like, why? I might fracture my spine. Oh, really? Did you tie your shoes today? She goes, yeah. I go, great, you can bend over and touch your toes, you're fine. And so we also had to work on her brain and the fear, which we'll talk a little bit about. So we got weight to be progressive and resistive. We got speed. The velocity is really important at tugging at those bones. And the last one is weight bearing. When I walk or stand, I am at 100%, one of my bodies. Does that make sense? When I walk, it's not much more force, so it's 1.1. When I march, it goes up to 1.5 of my body. When I run, that's a big jump, 2.6, because of the landing. Can you imagine if I was walking across this whole stage with a scale, and it was measuring how much force, how much weight I was giving it? The force goes up, and look, none of these exercises have weight. They're just how we move our body and interact with gravity in the earth, right? So step-ups. Step-ups are great, because I don't want to run. So step-ups, going up high and coming back down, jumping takeoff. You can put a lot of force into the ground, and the ground gives you force back. But you don't have to jump. It looks like this. I'm trying very hard to put force into the ground so it comes back up to me, through my feet, through my heels, through my legs, through my skeleton, right? Heel drops. Lisa and I, whenever we were done with this presentation, we always remember prunes, 1 Brazilian nut, and heel drops. I don't even have, that's it. That's it. Right there is 3.6 times your body weight. That's like, you can almost feel it reverberate through your bones and gives it some of that force. So, you're standing there waiting for your coffee to brew, you're doing 10 heel drops. You're standing there on the phone like, come on, you're doing some heel drops just to give it that force. Then we get into more of the jumping, a jump squat. So, when I teach athletes, I teach them to land low, land light like a ninja, right? Like, when I teach for osteoporosis, I want it hard. I want to make noise because I'm using the force, using that energy to come back up through the bones. Does that make sense? Foot stomps, a little even harder than your heel drop, and then we can get into vertical jumps and squat jumps if you're really excited about that. But you're like loading the spring and letting it explode. We're getting the fast plyometric part, and then we're getting the increase in body weight landing to make the change. Does that make sense? You are welcome to take pictures of this as well. So what I do when I meet with someone is I say, let's see where you are. Oh, I'm already a runner. Great, we're going to step-ups and heel drops and jump squats. Oh gosh, I don't even go out for walks. Well, we're going to start with walking and marching. You know, we may not get even to running. There's plenty of options out there that are safe for the knees and the back, right? So if you were to go out and say, number 3, I got to add my weight-bearing exercise, Kate told me, you just start at the top of the chart. And you do it for a week or 2. And, okay, my body feels fine. And then you can inch up that way. And then we're always here for you if you want a little bit more customized prescription. So here is some weight, and we got some speed, but you see how she gets some air time? She's trying to jump it up. Look at that. Doesn't that look like fun? Don't you want to go to that gym? Yes. Here's another one. Now, we talked about weight, and obviously, this is all weight in the legs. But guess what? We're susceptible to fractures in the arm, too. Wrist, shoulder. So we don't walk on our hands. I mean, I do, I coach cheer, so I do handstands, but everybody else, we don't put weight through our arms. So in order to stimulate change here, we need some weight through the arms. So here's a bear crawl or push-ups. And if you can't get on the ground and do push-ups, you do them at a wall, and then a counter, and you get lower, right? Or even just holding a plank. Holding a plank up here so that you get force through the wrist. We'll do things like clap push-ups where you're trying to do and land. Not necessarily gentle. Land to get that force through the arms. And higher is easier. And if you think, okay, that's good, next week you go a little lower. You go a little lower. Here's some more jumping, plyometric exercises. It doesn't have to be super speed. We don't have to be jumping through cones like those soccer athletes. Anything you do that's more, faster, heavier than you did yesterday is good. Just keep adding. Okay, so we know the 3 elements, and of course I love nerdy research, I don't know. This is my favorite article. It's called the Lift More Study, and it's just funny that it's called the Lift More Study, but it's, they took a big group of average 80-year-olds, and they said, you guys, do what you're doing. We're gonna send you to physical therapy, and you are going to do the sit and get fit exercise. And you guys over here, oh, you're gonna work. We're going to find your 1 rep max with 4 lifts. One is the deadlift, standing up. One is a squat. One is a shoulder press. And the last one they couldn't measure. It's called a jumping chin up. So I can't really do a pull up very well. But they would jump as high as they can and drop. 4 exercises. And they made them lift 85% of their maximum. Knowing that people go to the gym and do 30%, 85%. When I see some people do it for the first time, I go, oh my gosh, is this safe? Well, let's see. So 85%, 5 reps, because it gets so heavy, you can't do 10 or 15. 5 reps, 5 cycles. Study it. Some of them had very low T-scores, some didn't. Some of them were on osteoporosis medicine, some weren't. You can imagine that Group A and Group B were exactly identical. Here's what happened. Some got better. Chair fit got worse. The exercise program didn't make them worse. It just they weren't giving themselves enough load, right? And the biggest takeaway from the study is no one fractured. It's safe. It's safe. Don't be scared to really load the bones. Okay? Can you see, do you want me to explain any of these, or you're like, yeah, I trust you? It's just showing that the significant value of the T-scores, the percent change in the dark gray got higher, whereas the other ones got lower at certain sites. So let's go get some strong bones. Don't be scared. It's not going to hurt. It's not going to fracture, but you got to start somewhere. Anything you do is better than what you did yesterday, and if you need help because you're afraid, that's where we have some options. So I put together, just so you could walk out and try something, a couple of programs. So if you're saying, I am starting from scratch, I don't know where to start. Heel drops, wall clap push-ups with that land, modified jumping jacks, one at a time. I'm still getting some quick movement and some load. Marching, put on some good music and keep marching. Modified push-up, something higher, and the stronger you get, the lower you go. Modified planks, instead of a whole plank here, you could just do it from your knees, but I would encourage you to do it with straight arms so that you're getting something for the upper body. Crab crawls and bear crawls. So, you're on your hands and knees, and you just barely lift your knees, and you crawl across. Oh, that's a good one. Oh yeah. This is where I start to sweat in the presentation. And then sitting and standing like we just did. because they're squats, but there's something at the bottom, and inchworms, where you go all the way up to a plank, and all the way up, and then all the way out, and all the way up, and you make your way across the room. That's just the beginner program. When we get into jumping, you may not want to start jumping right away. It's with support. Have you ever seen those TRX systems, like straps? You can do something like that, or I could imagine like a towel with a knot around the door, and you're like helping to jump and land so that you get the height, and you get the landing. Actual jumping jacks. Drop to a push-up from your knees. You can see how it's a little bit more advanced. Burpees, we saw the lady do burpees, right, when she did the dog bone thing. Crab walks, so the crab, I think in the beginning, is crab bear hold. Just holding your knees up, and then you can advance it with walking. Farmer carry, you don't have to go to the gym and lift heavy weight. Load up your grocery bags with milk gallon, the cat litter's heavy, the salt in the winter is heavy. Just pick it up, and every time I have to do like my water softer pellets, I just think this is my exercise, and pick it up, and with beautiful posture, walking around. You could do one side, you could do the other, you could do both, but that's loading up your entire skeleton with more weight. Deadlift is you're in the gym picking up something heavy, which we will see in a second. Overhead, so we're getting some resistance through the arm and all the way down the spinal column. And a goblet squat, so instead of just sitting and standing with your body weight, you're doing squats, but holding something to make your body heavier. Does that make sense? Here's John. I think he's 89 now. This was last year, so we're doing our pull-ups, we're doing our jumping chin-ups, and we're doing our landing hard, push up, push away. So we have our plyometric, we have our upper body weight bearing, and we're deadlifting, and we started at 60, and he went to 160 pounds.
Wow.
And he didn't break, he improved. Okay? So, I think we're there. If I had to sum it up between Alison's talk about getting tested, what to ask the doctor, and our nutrition and exercise, this is it. This is it. Can I answer any questions? Yeah?
Does swimming do any good?
Swimming is better than not swimming, but think about the gravity. You're floating. So it is not a weight-bearing exercise. It does have some speed, right? So you got one, and it's not progressive resistance. Maybe you'll go longer and progress your endurance, but unless you added like fins and paddles that make it more resisted, then you would get 2 out of the 3. So it's better than nothing, but if you were really trying to target your osteoporosis, I would stay away. I think I saw somewhere that collegiate swimmers, as strong as they are, they have to start doing dry land practice, because later on they could get osteoporosis, because in their peak building years they were in school. Right? Great question. Yeah?
What are those smaller trampolines with the bars on them they talk about? Do you recommend those?
Oh yeah, it's jumping.
Yeah.
Yeah, it's jumping, it's plyometric, so it's those quick movements. The only thing lacking is it's a soft landing instead of the hard landing. So yes, better than nothing. Actually, I think it would be very good. If you want to do an A+, take all those jumps and put them on the floor. Yeah.
About Pilates?
Same, so it's weight bearing. It's a lot of strength work in those like isometric holds and those flows. But unless you're on the reformer where there's actual resistance, I don't know how much it adds speed to it, but it's, again, good, not bad, but it could be better if it added more weight, more resistance. And as long as you keep making it, what's nice about class is the classes keep saying, oh, that's easy, a little bit more, a little bit harder. So I think it depends on what type, because you want to make sure you're getting the right resistance, but it is a lot of weight bearing unless you're just laying down on the reformer the whole time. But then you have resistance. Yeah.
They also have a, it's called a jump board.
Yeah.
You're actually like on the reformer, but you're pounding, like on
Good.
your legs, on your feet.
Ding, ding, ding. And that's a great way to be jumping. So we're getting the weight bearing, the plyometric, and the resistance, but maybe it's less than body weight because you're laying down.
Right.
So if you're jumping on the ground, it's body weight times 3, 4, 5, 6. This might be half, 1, 2, it depends. You'd have to put a force plate on it to measure how much you're actually getting. But I think that's great. Yeah.
Yes, the example of targeted exercises, is it possible to get a copy of the page?
Yeah. Do you have a phone? Would you like to take a picture of it?
I could do that.
Yeah, otherwise at the end or on any of our RVNAhealth materials, I think there's my email. If you email me directly, I would love to send you. If you email me directly, I can send you these. Yeah.
I'm going to take a picture.
Okay, very good. What else, even if it's not for me, anything for Allison? If you, yes.
I walk every day and it sounds like it's not really doing much. What can I do while I'm walking?
That's a great question. Add weights. Hold dumbbells while you go. You could get really brave and get a weighted vest, and they start light and they can go up to, I don't know, 20, 30 pounds. So you could put a vest on so that your body is heavier while you're doing that. You can add some speed. If you can't just magically go faster, you do intervals. For 30 seconds, I'm gonna walk really, really fast, and then for a minute, I'm gonna chill. And then you work it up to the opposite. A minute fast, 30 seconds rest, and then all of a sudden, you're just walking fast. So faster. Incorporate hills, because hills are harder. And down, if you go uphill, that's great for hard, and if you're going downhill, that's harder for landing. So that's a good way to make walking just a little bit more effective. If you don't know where to start, that's what the physical therapists are for. And I told Allison, you know, when I was in school, we were told osteoporosis, caution, be careful, don't break them. I don't think we really got the targeted exercise approach. So it's not until I went and did the research to really learn enough to be able to do these presentations that I gained the confidence. So just because there's physical therapists, I love them, they're great. They went to school, they have the ability to do this, but they, you know, just say, hey, did you read about the Liftmore study? And if not, go read it, now treat me, that kind of thing. Or come and find us. And if you're ready for a group class or you just want some ideas, we do offer 2 classes in town. Balance and Beyond is Mondays and Thursdays at RVNAhealth, and Thursday we have Strength and Beyond. That's where we're actually lifting a little bit more weight, and this is the perfect clientele for that. You are all welcome to come, and we hold it at Steel Fitness, which is right down next to Parma Deli. So when you're done, you go over and get a cupcake. So if you want more information about those classes, just to give you ideas, either that's your thing, I like classes, and I like the John loves to socialize, or great, I have some ideas, that was way easier than signing up for therapy, and you can continue doing them on your own.
Yeah. If you would know where to start, just go in the back and get the flyers.
Yes, absolutely.
I have a new fracture, I'm like a beginner here, so I have to work my way to get healthy and start. But I want to work with someone to help me, but I'll pick up flyers on the way out.
Absolutely, our pleasure. Yeah.
So what would you suggest, say you have like family or friends that, you know, they have that misconception that if I do anything weight loading or anything weight bearing, I'm gonna hurt myself, and they have osteoporosis, but they're too stubborn to go to physical therapy or to go to someone. What's the best way to kind of introduce the topic to them?
So we all, I would say, all of our bone densities are going down. And osteoporosis is starting lower and still going down. And what might be happening is it's going down faster. If you do nothing, it will get worse, guaranteed. Do something. Anything you do, swimming, add some resistance, walking, add a little weight. Nothing, just get up and move and do some sit-to-stands. Anything you do is better than nothing, and there are professionals there to help you figure out what is safe. But, and I mean, I'm a nerd, so I would point them to the Liftmore study and say, look, Look at how hard these people work. You don't even know what it's like. You don't even know what your capability is. You are stronger than you think. And no one fractured. So it has, thank you for the misconception. It has been proven that this is safe. And you have to live your life. If you stop doing things because you're afraid, sure enough, you will do less and less and less. So at the minimum, you have to keep doing what you're doing. Just because you walked out of that DEXA scan with a low T-score doesn't mean that you got osteoporosis today. If yesterday you were doing it, you better not stop, right? Well, we'll be in the back. Yeah, one more.
A physical therapist one time, many years ago, I went to physical therapy for osteoporosis in my spine. And she told me never to lift anything more than 25 pounds. So all this time, I'm thinking, oh my God, I better not lift anything more than 25 pounds.
Again, there's definitely misconceptions. Research is always coming out, and we just have to hope that our medical professionals are up to date on all the literature so that we can make the best decisions for our patient. And maybe your case was different, maybe your T-score was so low.
No.
When I meet my osteoporosis patients, I ask them to bring their T-scores and DEXA scan results, because I'm also looking at, they come in, I have osteoporosis from my head to my toe, and I look and I go, actually, it's really just your hip, it's your arms that we have to worry about. So let's focus on arm exercises. Or, it's just your spine, but your hip is good, arms are good. I'm gonna tailor a program that is beneficial, but not too much on the more susceptible spots. So I can make an informed decision about what is safe, but not nothing. Because did you lift 25 pounds the day before she told you to stop? So why would you do it tomorrow and all of a sudden break?
You know, I don't remember, it was so long ago.
Yeah, I haven't seen what date this lift more thing was. It's not in there, but it's pretty recent, like 5 years or so.
2018.
Was that 2018? Okay, good. So it's been around. Well, I want to say thank you one more time. We'll be around to answer more questions for you, and I appreciate you all coming out. Thank you.